Evening, everyone. Thank you for joining us today. As you may be aware, November is Lung Cancer Awareness Month, and we are running a series supported by Roche Diagnostics on the different aspects of lung cancer. And today we will focus on the pioneering progress in lung cancer, specifically looking at screening, diagnosis, and treatment, and how things have improved, and what are the challenges still ahead. But also, I think it's important for us as patients to understand, as patients or as caregivers of patients, to understand this so that we can manage our journey with some of these challenging conditions better. We are very privileged to have with us Dr. Amit Rauthan, who is the HOD and consultant of medical oncology at Manipal hospitals. Dr. Thomas Alex Kodiet, who's a professor, thoracic lung pathology diagnostics, CMC Vellore, and Mr. Ravi Prakash, who is a lung cancer survivor, stage 4 lung cancer, and a patient advocate and director of Lung Connect, a NGO that works in the space of spreading awareness on lung cancer. And as I said, that this series is supported by Roche Diagnostics. Last week, we did a session with Mr. Vivek Kumar, again, another patient advocate and caregiver to his wife who passed away, and Dr. Sevanti Limay and Dr. Rekha Pai on some of the other aspects of lung cancer and the innovations. And next week on 28th, 2 p.m. Indian time, we will be talking to Dr. Naresh Somani and Dr. Vidya MN on the myths and facts around lung cancer. So, if you have a question, you have a concern, please drop in a note or join us on 28th November, 2 p.m. A quick reminder to all of our viewers, as some of you may know and others may be new to this, Patients Engage is an online platform for patients dealing with chronic diseases and for them and their caregivers to share personal experiences, learn from each other, as well as from healthcare professionals. And what we really believe is that nobody should need to fight or deal with any of these conditions alone. And the better informed you are, the better choices you make and better outcomes you have. And I'm Aparna Mittal. I'm the founder of Patients Engage and the moderator for this session. Again, a quick guidance to the viewers that this session is for spreading awareness. The views may not reflect that of the publisher or the sponsor, and the information does not replace a medical consultation. So please do consult your doctor for specific medical issues. And, you can contact us through any of our social media channels or the website patientsengage.com, or you could write to us at editor@patientsengage.com. And if you are following this live on YouTube, on Facebook, or on Roche's channels, you can drop in your question and we will try and address it either during the session if we're able to get it, or in the next session. So let's get started. Thank you once again to our panelists for joining us today. Dr. Rauthan, let's start with just making sure that everybody who's watching this is aware of what is lung cancer and what are the early symptoms of lung cancer.
Thank you, Aparna. Thank you for having me here today. So, lung cancer is a cancer which arises from the lung tissue, and it is one of the most. It is an aggressive type of a cancer where we say it's a growth of abnormal cells in the lung which grows and then causes various symptoms due to the pressure effects it creates or due to other effects it creates by spreading. So we have various types of lung cancers, but effectively most of the symptoms which start off are because of the mass which is growing in the lung and pressing onto the lung tissue. So it may press on and they can cause cough if it is pressing on the bronchus. It can press onto our central bronchus and cause bleeding. It can cause breathlessness. Sometimes it can, as it spreads, it can cause fluid to form, which make patients more breathless. There can be chest pain. And if it spreads to other organs, which happens as the disease nature spreads, it can affect other organ systems. So it can cause bone pains when it spreads to the bones. It can cause spread to the brain and cause abnormal brain behavior. It can go to
Right.
liver and cause jaundice. So these are the various symptoms which lung cancer can present with.
Right. Thank you. And what are the risk factors for lung cancer?
The the most important risk factor we talk about is smoking and exposure to smoking. So
Hmm.
this is something that we've always attributed lung cancer and smoking, and they always go together in our minds. And we know that we always are dealing with, the more the history of smoking, the more exposure to smoking, the more chance of developing lung cancer. But we also need to know, nowadays we see a lot of lung cancer in non-smokers. So that
Correct.
there is a population who is not a smoking population who is developing lung cancer, and there are different risk factors for that. It could be environmental exposure due to various. We talk of exposure of smoke through radiation, through secondhand smoke, or it could be exposure due to other environmental agents in pollutants which can cause lung cancer. And there's a background exposure of radon which can cause sometimes lung cancer. And we also say exposure to radiation sometimes for various reasons in early life can cause lung cancer. But yes, in general, smoking is the one which we say we attribute maximum, because we know this is something can be prevented by preventing smoke.
Right, right. I'll come to you, Ravi ji, and just to let the audience know that Ravi ji will primarily speak in Hindi, whereas the other two panelists will speak in English. Ravi ji, आपके जो शुरू के symptoms थे, initial symptoms थे जो lung cancer के diagnosis जो आपको फाइनली हुआ, तो उसके बारे में आप थोड़ा बताइए, और कितना टाइम लगा डायग्नोसिस के लिए?
देखिए अपर्णा जी, पहले तो थैंक यू आपका कि आपने ये मौका दिया कि हम बात करें। और मुझे जैसे कि डॉक्टर अमित कह रहे थे कि नॉन स्मोकर्स को हो रहा है, आई एम ए नॉन स्मोकर, नेवर स्मोक, आई मीन एक्चुअली नेवर स्मोकर, आई एम बैटलिंग विद लास्ट स्टेज लंग कैंसर। तो एक ये बात है। दूसरा कि मुझे खांसी थी, मामूली सी खांसी, कोई बड़ी मतलब कोई बड़ा नहीं था जिसकी वजह से डॉक्टर के पास जाए। बट मैं डॉक्टर के पास गया, और जब मैं डॉक्टर के पास गया शुरुआती अपने मतलब घर वाले इलाज के बाद, क्योंकि मुझे लगा था कि ठीक हो जाएगा, जो नहीं हो पाया। तो मेरे जो पल्मोनोलॉजिस्ट थे यहाँ के, क्योंकि मैं रांची में रहता हूँ, झारखंड के कैपिटल में, तो उन्होंने 5 दिनों में ही फाइंड आउट कर लिया था कि मुझे कैंसर है लंग का। क्योंकि पहले उन्होंने एक्स-रे किया जिसमें वो प्लूरा डिफ्यूज़न दिखा उन्हें, इफ्यूज़न दिखा, उसके बाद वो निकाला गया पानी, उसकी जाँच हुई, उसमें आया नहीं। वो उसमें मैलिग्नेंसी नहीं थी। तो फिर हुआ कि एक सीटी स्कैन कर लिया गया, तो मेरा सीसीटी स्कैन हुआ थोरैक्स का, उसमें दिखा कि हाँ कैंसर है। फिर उन्होंने सजेस्ट किया, और इस सब में मुझे 5 दिन का वक़्त लगा। मतलब मैं 26 जनवरी को 2021 में गया था डॉक्टर के पास, और 30 तारीख को मेरे पास रिजल्ट था कि मुझे कैंसर है। बहुत जल्दी हुआ मैं।
बहुत जल्दी हुआ, बहुत जल्दी हुआ। तो Dr. Rauthan, is that normal? I mean, is that the diagnostic process that Ravi ji went through? Is that the typical diagnostic, or is that the ideal diagnostic process? And what are the challenges that most people face? Because we know that most cases of lung cancer are diagnosed late in any case.
Yeah. No, it's good to see. So it's unfortunate to see Ravi's diagnosis, but it's good to see that he got diagnosed in 5 days, which is so surprising.
Mm.
It's many a times in India, what would happen is the patient will have come cough and they will go to a primary physician. The primary physician will say, no, this is just viral infection. This is some infection. Give antibiotics. Then they'll say, come back after a week, 2 weeks. Then patients go, it doesn't get better, then they go somewhere else, then they get evaluated by a basic x-ray, and then again the diagnosis gets delayed more and more till they end up with a specialist, with either a pulmonologist who diagnoses it, or sometimes to an oncologist who diagnoses it. So unfortunately the reality in India is it takes time, because of the various steps of going through various doctors, because not everyone is aware of what all tests are required for lung cancer. But yes,
Okay.
the good thing is those, now the awareness is getting more and more. Even patients are more aware. So now patients
Mm.
who have cough purposes, and they try and sometimes end up with a pulmonologist directly. And pulmonologists are very aware about how to look for lung cancer, how to evaluate for lung cancer. So eventually it requires that high level of suspicion, which is required not only on the patient's side but from the doctor's side. So
Doctor
we say
side.
physicians should have a high level of suspicion for lung cancer, and once they are suspecting it, the best thing is to do a CT scan. So sometimes don't rely on an X-ray. Do a CT scan, and with a CT scan, when you see a suspicious nodule, then take it up to the next level. Do a biopsy, and then come to the conclusion, which I think for Ravi, it happened really rapidly, and it was good to get that diagnosis so rapidly. It's heartening
Right.
to see that happens in many places also.
Right, right. So, coming back on that, I think the other thing that I'd like to add at the moment is we're seeing earlier it was cough, and people got treated for just cough, or they got treated for TB. But now we are also seeing sometimes people delay seeing because they think of it as a pollution-related allergy. So we've seen cases where they've gone to ENT specialists and so on as well. Any effort being done to kind of let other specialists as well know that they should be equally suspicious? And this is to anybody in the panel, actually.
Yeah, I think almost most, at least oncology departments are kind of associating with other departments. Like we associate with pulmonology, and pulmonology is associating with physicians, and that way the information is being spread more and more. The whole message that lung cancer need not be a fatal disease, and it's not. You can do a lot these days, and that's the whole message which is going out. And it's good to see that many people are adopting early detection. But yes, I know we will discuss early detection, but early detection is something in India which is not yet there, and it will take a long time for it to come. But at least early diagnosis by keeping a high threshold of suspicion is what I would emphasize on.
Right, right. Dr. Thomas, do you want to add anything?
Yeah, hi, thanks for having me on the show. So what I can add on this is the biopsy part. So many a times, Dr. Rauthan says, they come to the primary physician, come for cough, they treat them for viral or whatever the infectious part of it. So when it constantly happens, like a non-resolving sort of pneumonia picture, then they do the biopsy after probably 2-3 months of not resolving for the treatment. And then there's a surprise answer to the diagnosis. I mean, there's cancer in the diagnosis. So these sort of things, I do see that now biopsies, they don't suspect at all, but after 3-4 months of constantly treating, they find out there is a hidden cancer sitting in the tissue.
Right.
But yes.
Right. And after you've got to the biopsy stage where you've now figured out that it is lung cancer, what are the other diagnostic tests done, and why are they done? The reason I ask this question is sometimes patients get very confused as to, the number of tests they're going through. So we just want to make sure that they understand the role of each of, the various types of tests. So Dr. Thomas, do you want to talk about that? And
yes, shall I start off with the biopsy part so that I can direct because lung cancer is an umbrella of many cancers. So lung cancer is just the umbrella term for carcinoma, and in the lung we have something called as non-small cell carcinoma and small cell carcinoma. So why they use the word is because the treatment is different for both, and the mutations are different for both. So most of the time, the most common one is non-small cell carcinoma, and when we receive that in the biopsy, we try to help the oncologist and the pulmonologist trying to subtype the non-small cell carcinoma. Many a times it turns out to be an adenocarcinoma or a squamous cell carcinoma. There are other variants as well, but these are the two common ones: the adenocarcinoma and small cell carcinomas. Squamous cell carcinoma. And to diagnose this, it's basically on the microscopic slide, as well as sometimes we use extra tests like immunohistochemistry. That takes additional 2 days after the biopsy comes to us on our table. After that, we assign it out as adenocarcinoma or squamous cell carcinoma, and then the oncologist, or sometimes there's reflex sort of testing, but the oncologist tells us, please do the further tests. So that's where Dr. Rauthan, do you want to step in, or should I? Because it's a common overlap for both of us.
Yeah, I think both of you can kind of address that from your both perspectives. Yeah.
So for us, it's so important. The pathologist is giving us the diagnosis that histopathology is saying adenocarcinoma or squamous cell carcinoma. And there was a time many years back when we used to be happy with this report and say adenocarcinoma and squamous and start treatment. But now it's changed dramatically. At least in the last 5 years, everything has changed because we are looking for molecular subtypes of lung cancer. And we divide Even our adenocarcinomas are divided now into 9 to 10 types of adenocarcinomas. And these are called molecular-driven adenocarcinomas. It could be something known as a GFR mutation, an ALK rearrangement, a Roche rearrangement, a RET, and there are multiple abnormalities. And we need to find out this at diagnosis, which is the one we are dealing with. And when we know what we are dealing with, we can prognostify our patients. We know some patients are going to do better, some not bad, but we have better ways of treating our patients. So for us, very important, we need these sequencing NGS testings, which we ask for to get into which subtypes of adenocarcinomas which we are dealing with. Even testing is becoming important for other subtypes of lung cancer. So for us, it is so one thing we keep saying is we need that tissue to get the test done, but we are also doing these days blood-based testing. But we need to find the exact subtype of lung cancer we are dealing with.
Right, right. So, Dr. Thomas, on that, can you kind of, there are all these terms used, right? Molecular testing, biomarker testing, gene mutation testing, NGS. Can you kind of, which are synonyms, which are different? Can you just demystify that so that, patients or the public is clearly aware of each of these?
Sure. So basically, gene mutation means some change happening in the gene or genome of the tissue or the human being. So now we are talking about cancer DNA. We're not talking about the human DNA. So even the tumors have their own DNA. So we're talking about the gene mutation or molecular mutation in that tissue. So there's a change in the gene. So that is what is known as gene mutation. And there are tests involved. And so that's what it's called molecular / gene mutation testing. Now, what are these biomarkers? Biomarkers are nothing but just a characteristic which can be objectively measured in that tissue, which tells us, or is an indicator or sign of an underlying normal or a biological or pathological process or some response to a drug intervention. So that is what's biomarker. So that's what biomarker has many roles. It can be a diagnostic biomarker, it can be screening biomarker, it can be a prognostic biomarker. In lung cancer, we are dealing with a predictive biomarker. Basically, it tells you the predicting response to a particular underlying targeted therapy. So that's why it's called predictive biomarker. Now, what is NGS? So NGS, so all this, so what I talked so far, genetic mutation, molecular mutation, we are testing the particular target gene. So for example, now Dr. Rauthan was talking about EGFR, ALK, ROS. So there are multiple targets. So if I test each tissue at one time, so one point before the popularity of NGS, we used to test each at a single time, like EGFR at one point of time, single gene testing basically.
Correct,
ALK, ROS. So what happens to that is the tissue gets wasted. So
yes.
as Dr. Rauthan says, tissue is the main thing here. And as pathologists, we are the custodians of the tissue. We try to minimize wasting the tissue. So when we get a case of tumor itself, we don't unnecessarily waste the tissue for other markers. So we try to make a diagnosis of adeno and squamous cell carcinoma and then proceed it for the further tests. Now, what is NGS? So NGS is one platform. It's where you can run all these multiple gene testing in one shot itself, though it is slightly more expensive than the single genes to get single at a time. If you do it all together at one point of time, it actually saves a lot of money, and you can actually save a lot of tissue. You can also save a lot of time as well, because when you do single gene testing sequentially, it wastes a lot of time and delays the treatment. So correct. It's important here when you're using NGS.
Correct. Yeah, no, I remember some of our conversations with patients who probably were earlier in the, a few years back when I think NGS was either too expensive or maybe not accessible. So they would struggle, each test would come back, then more tissue was needed to send back, etc., etc. So I think some of them talked of losing months in the process, and really caused a lot of anxiety and stress in the patient as well. Ravi ji, if you can tell us कि आपको जैसे आपका lung cancer का biopsy हुआ, उसके बाद आपका process to get to आपका EGFR है, तो उसका diagnosis में फिर कितना time लगा, और आपके अलावा पेशेंट्स को आपके हिसाब से जो आप बात करते हैं, क्या चैलेंजेस होते हैं इस लेवल के टेस्टिंग के लिए? आई थिंक बायोप्सी तो शायद कई जगह में मिल जाती है, पर उसके आगे का जो डायग्नोसिस होता है।
देखिए, जैसे डॉक्टर थॉमस कह रहे थे, एग्जैक्टली वैसा ही मेरे इस डायग्नोसिस में हुआ था। मेरी बायोप्सी हुई, जो सिटी गाइडेड थी, TMH मुंबई में, टाटा मेमोरियल हॉस्पिटल मुंबई में हुआ था। और उससे पहले मुझे डॉक्टर ने ये कहा था कि बिकॉज यू आर नॉन स्मोकर, तो हम लोग आपका जो है मॉलिक्यूलर टेस्ट भी करेंगे। और मेरे 4 मतलब हर EGFR हुआ, अल्क हुआ, रॉस हुआ, PDL1 हुआ, ये सबकी टेस्ट की गई। और मुझे ये बताया गया कि 20-22 दिन लग जाएंगे सारी रिपोर्ट्स आने में। तो तब तक आपको वेट करना होगा कि यू हैव टू वेट कि भाई सारी रिपोर्ट्स आ जाएं तो हम एक प्रोटोकॉल तैयार करेंगे जो फायदा करेगा। बट मुझे जल्दी थी ट्रीटमेंट की, तो मैंने कहा कि नहीं, मुझे कीमो तो कर दीजिए, मुझे पता चल जाए कीमो कैसा होता है। तो मैंने एक कीमो कार्बोप्लाटिन वाला करा लिया था रिपोर्ट्स आने के पहले ही। बट जो मेरा तो वैसे हुआ, बट जो चैलेंज आता है ना कि जो पेशेंट्स के सामने, जैसे जब मेरा 2021 में ये प्रोसेस चल रहा था डायग्नोसिस का, अर्ली मंथ्स में, फरवरी में फैक्ट, तो 40,000 कुछ की टेस्टिंग थी ये TMS में। बाहर के हॉस्पिटल्स में आप जाएंगे, कॉर्पोरेट हॉस्पिटल्स में, तो ये रेट और भी ज्यादा है। तो 40,000 रुपया एक डायग्नोसिस के लिए लगा देना गांव के किसी आदमी के लिए या वैसे आदमी के लिए जिसकी इनकम उतनी नहीं है, तो एक बड़ा चैलेंज होता है। कि मतलब आदमी जब टमाटर खरीदने जाता है और सोचता है कि 100 रुपए का टमाटर है, तो हेडलाइंस बन जाती है इंडिया में या दूसरे देशों में भी पास के। तो जब 100 रुपए किलो का टमाटर हेडलाइन बन जाता है मीडिया में, तो 40,000 रुपए का टेस्ट भी तो उतना ही हरास करता है ना किसी पेशेंट को, जिसको ये पता है कि उसको कैंसर हो गया है। और अनफॉर्चुनेटली इंडिया में या इंडिया जैसे दूसरे देशों में, इवन वेस्टर्न कंट्रीज में भी, लंग कैंसर क्योंकि के ज्यादातर मामले एसिम्प्टोमेटिक होते हैं, तो सिम्टम ही नहीं है तो आप स्टेज 4 में डायग्नोस होते हैं। तो तब 40,000 रुपए करना और भी टफ होता है। तो हम लोग ये कहते हैं एज ए पेशेंट एडवोकेट, और जो लंग कनेक्ट है इसमें पेशेंट एडवोकेसी हम लोग करते हैं लंग कैंसर के पेशेंट्स के लिए, कि भाई ये एक जो जांच है, ये जो इंश्योरेंस कंपनियां जो मेडिकल इंश्योरेंस करती हैं उनको इसमें इनरोल करना चाहिए कि वो करा दें, इसका पैसा वो दें, क्योंकि ऑलरेडी हम प्रीमियम अपना पे कर रहे हैं। प्लस जो गवर्नमेंट की जो स्कीम्स हैं जो ठीक ठाक हैं, अगर मान लीजिए कि किसी मरीज का आयुष्मान स्कीम के तहत वो बेनिफिशियरी है, तो उसको 5 लाख रुपए का कवरेज तो मिल ही रहा है ना साल में। तो 5 लाख रुपए में से 40,000 रुपए आप निकाल सके टेस्टिंग के लिए। अनफॉर्चुनेटली वो अभी नहीं है इंडिया में,
वो नहीं है
तो
ना।
नहीं है। तो मेरा ये कहना है कि क्योंकि अगर आप चाहते हैं कि आपके मरीज की लाइफ प्रोलॉन्ग हो, बिकॉज यू नो कि स्टेज 4 में अभी आपके पास जो प्रोटोकॉल्स हैं, जो एजेंट्स हैं, आप उसकी लाइफ को बचाने नहीं जा रहे हैं, आप क्योर नहीं कर पाए। तो जब आप क्योर नहीं कर पाएंगे, तो कम से कम क्वालिटी ऑफ लाइफ दें, उसको सेटिस्फैक्शन दें, एंजाइटी से बचाएं। तो ये तब हो पाएगा जब फिनेंशियल बर्डन कम होगा उसके ऊपर। तो मैं ये कहता हूं कि जो भी इंश्योरेंस स्कीम्स हैं, गवर्नमेंट को एक ऐसा प्रेशर ग्रुप बनाना चाहिए जिससे कि इंश्योरेंस के स्कीम्स में वो जांच आ जाए। प्लस आयुष्मान योजना जो गवर्नमेंट की अपनी योजना जो किसी बीमा कंपनी के साथ मिलकर गवर्नमेंट करती है, तो उसमें तो उसको शामिल कर ही लेना चाहिए, ताकि कम से कम डायग्नोसिस तो हो जाए एक मरीज का अच्छी तरीके से।
जी जी। आई थिंक हाल ही में 1-2 स्टेट गवर्नमेंट्स में शायद वो डायग्नोस्टिक टेस्ट इंक्लूड किए हैं, मॉलिक्यूलर टेस्टिंग। आई थिंक शायद 1-2 स्टेट गवर्नमेंट्स का अनाउंसमेंट तो आया है। तो आप पता नहीं आपने नोटिस किया है कि नहीं, बट हाँ, आयुष्मान भारत में अभी नहीं है अब इसमें। So I think, Dr. Thomas, currently what is, I mean, because we've moved to NGS and we still have the other tests, typically how long does this process take for the various tests? Because as Ravi ji also said that it is extremely, he started on chemotherapy in the meantime while waiting for his tests. So, what's the progress in this space to reduce the time for that all these tests?
Sure. So starting from the biopsy would roughly take around maximum 2 to 3 working days from the time of receiving it. Then after that, if the single biomarker testing is ordered for example, EGFR single, I'm not talking about NGS right now, just single. So EGFR takes at least 4 to 5 working days, maximum 7. ALK, Roche, all that, again, it's on basically there's other platforms known as FISH and IHC. So those again will take 1 or 2 working days. So to cut short all this, we decided, it is going into the trend of NGS. So the thing about NGS is the information that you get is multifold. There's a lot of information. So for a molecular pathologist to interpret that, there's a lot of interpretation filtering to do in the NGS data itself. But the turnaround time for regular NGS is usually 3 weeks, but it can be cut down to 2 weeks itself. And there are a lot of advances being made right now. It's just evolving. It's a lot of evolution in this field, and they're saying that it's going to come down to even 1 week, even lesser than that. But there's a lot of interpretation because there's a lot of data that comes out of NGS. So there's a lot of things to be compared with standard protocols and all that. But definitely at the moment it's 2 weeks, but can be done under 2 weeks. But I think it's coming down to 1 week also. That's what the Western data is showing, under 1 week.
Right. So Dr. Rauthan, how does, as an oncologist, once all of these tests come in, do you need to wait for all of them to come in before starting any treatment protocols, or are you able to start anything in intermediate? How do you approach that from a treatment perspective?
So for us, once we have a pathology report saying adenocarcinoma and squamous cell carcinoma, which Dr. Thomas told us just takes us 2-3 days, and we have that information, we go by the patient's symptoms. If our patient is symptomatic, we start treatment with chemotherapy, because chemotherapy is broad spectrum. It is acting on most of these cells, and there are chemotherapy protocols which slightly differ between adeno and squamous. So that information is good enough for us. And I think it was like Ravi ji mentioned, he took treatment with carboplatin, which is perfectly good. If for a symptomatic patient, starting some chemo slows down the disease process, gets their symptoms down while we wait for the NGS reports. Now, we get our NGS reports sometimes in 1 week, sometimes in 2 weeks, depending on where we have sent it out. There are multiple labs doing it. So eventually, once we have the NGS report, then we plan our treatment. Now, if it is a squamous, we know NGSs may not be that important, though we still do it for looking for rare markers. But most of these patients would require treatment with chemotherapy. Now, that's where advances have happened. In patients who require chemo, one can think of adding immunotherapy for squamous cell carcinomas, and that has made a tremendous difference in certain group of patients, especially the PD-L1 positive patients. So that's the reason why we are doing PD-L1 testing for all our patients. Strong PD-L1 positive patients, sometimes you can even use immunotherapy alone. But again, there are issues with immuno in India. Cost is always a major barrier for immunotherapy. So we use chemotherapy, or we use chemotherapy plus immunotherapy. In adenocarcinomas, once we get the NGS report, we know which subtype the patient sits in. Now, we are always very happy if patients come into the EGFR, ALK, ROS, RET, one of these subgroups, because they do so well with oral tablets. We don't hesitate in stopping their chemos, putting the EGFR patients on tablets for anti-EGFR, or ALK into tablets which work very well for ALK fusions. And these patients then are continued on tablet-based therapy, and most of them would do very well. Now, the adenocarcinomas where you get NGS is negative, now those patients, again, chemotherapy with immunotherapy is the way forward. Again, provided the immuno can be got in financially. Otherwise, it is chemotherapy alone. And by chemo, we try to get our best responses. So it is integrating chemotherapy and immunotherapy for the non-molecular driven cancers, and it is integrating molecular targeted drugs for our patients who have a molecular drive. And that's why the whole emphasis on getting the molecular subtype.
Right. And we got a question from the audience is, which is the most common type of lung cancer in India?
Alex, you want to take that?
Yeah. Common is non-small cell carcinoma. Non-small cell.
Okay.
Yeah.
So
so there was a time when we used to say in India, some years back, squamous cell was more, but now adenocarcinoma is much more prominent in India, and it's just like in the West, adenocarcinoma has become much more prominent. And among the adenocarcinomas, we have a lot of EGFR-driven cancers, much more in India than in the West. And that's good because EGFRs are where the tablets can work well. So we say about 25-30% patients of India have a EGFR molecular-driven type of adenocarcinoma.
Right. And in terms of, I think we also received a question in terms of, yes, you said typically chemotherapy or targeted therapy or immunotherapy. Is there any role for radiation therapy at all for a lung cancer patient?
So unfortunately, most of our lung cancer patients are detected in stage 4. So at least 70-75% of our patients are being seen in stage 4. In stage 4, there is a limited role of radiation. You do radiation if you have multiple bone metastases which are causing severe pain, or a metastasis in the spine which is causing pressure on the spinal cord, that's where we do metastasis for palliation. Also,
Right.
if you have a brain metastasis, we try to radiate isolated brain lesions. We are moving away from giving whole brain radiation. We don't do that much any longer in lung cancer. We try to
Right.
radiate only the spots which we think are symptomatic. So that's in advanced stage, this is the indication of radiation. But if we see early stage lung cancer, especially when we talk of stage 3B or 3C, that's where we do treatment with concurrent chemo and radiation together. And that's where radiation has an integral role.
So the consistent message, kind of keeps coming every time we have these discussions, that there is a lot of progress, there are better outcomes for patients, but, kind of cost is a big issue for large parts of the population, right? And significantly big issue. Ravi ji, आपके हिसाब से what are some of the initiatives or kind of changes that you would like to see or that you advocate for on that front?
देखिए, जो कॉस्ट का मामला है इंडिया में, जो पर कैपिटा इनकम है उसके हिसाब से कॉस्ट काफी प्रभावित करता है हर एक मरीज को। इवन डॉक्टर्स भी जानते हैं, और इस वजह से डॉक्टर्स के पास दूसरे तरीके भी, वो कहते हैं कि ठीक है, अगर आप इसके साथ नहीं जाना चाहती है तो ये एक दूसरा ऑप्शन है, दूसरे के साथ नहीं जाना चाह सकते तीसरा ऑप्शन है। तो ये एक होता है, जैसे मैं EGFR पॉजिटिव मरीज हूँ स्टेज 4 का, और मुझे जो फर्स्ट लाइन ड्रग बताई गई थी मैं उसको नहीं ले पाया था बिकॉज वो कॉस्टली था। तो मेरे पास एक सेकंड ऑप्शन था जो डॉक्टर अमित बता रहे थे कि ठीक है, जैसे इम्यूनोथेरेपी प्लस कीमोथेरेपी करते हैं, तो मेरे पास एक ऑप्शन था कि इम्यूनोथेरेपी प्लस टारगेटेड थेरेपी के साथ हम जाएं, जो कॉस्ट इफेक्टिव था, तो हम गए। चैलेंज ये है कि जब आप एक ऐसी कंट्री में किसी मेडिकल प्रोटोकॉल को सजेस्ट कर रहे हैं या लागू कर रहे हैं जिसकी पर कैपिटा इनकम काफी कम है, तो उसके हिसाब से आपको यह तय करना पड़ेगा कि आप उनके लिए क्या इनोवेशंस कर रहे हैं। जैसे लास्ट टाइम 10 दिन पहले मैं डॉक्टर कुमार प्रभास के साथ था टेलीविजन के शो में, जो KMH मुंबई के HOD है मेडिकल ऑन्कोलॉजी के। उन्होंने कहा कि अच्छी बात की, जो मैं कोट करना चाहता हूँ दोबारा यहाँ, उन्होंने कहा कि ठीक है, आप अगर रिसर्च कर रहे हैं और आप इन्वेंट नहीं कर पाए तो इनोवेशन कर दीजिए। तो एक इनोवेशन था, टाइप ऑफ इनोवेशन की मुझे ये मिल गया कि मैं उसके पैरेलली, अगर टारगेटेड थेरेपी कोई एक पार्टिकुलर दवा नहीं ले पा रहा हूँ, तो उसके पैरेलली लगभग उसके ही आउटकम के हिसाब से मैं कीमोथेरेपी प्लस टारगेटेड थेरेपी की एक कॉम्बो पे जा सकता हूँ, तो कॉस्ट इफेक्टिव। तो हर एक डॉक्टर को, मेडिकल फर्टिलिटी को, फार्मा कंपनीज को, इवन गवर्नमेंट को भी ये सोचना चाहिए कि हम वैसे प्रोटोकॉल्स को इंडिया में लागू कराएं जो कॉस्ट इफेक्टिव हैं, और जो भी बीमा की प्लान्स है ना, चाहे वो प्राइवेट हो चाहे वो आयुष्मान जैसी सरकारी योजना हो, आप शामिल करें। आप ये ना बताएं यू आर नॉट ए डॉक्टर। भाई, प्राइम मिनिस्टर डॉक्टर तो नहीं है ना भारत का, या किसी स्टेट का चीफ मिनिस्टर, ही इज नॉट ए डॉक्टर। मैं एक पेशेंट हूँ, जब मैं डॉक्टर के पास जाता हूँ तो मैं जानता हूँ कि आई एम नॉट एन ऑन्कोलॉजिस्ट, तो मुझे जो डॉक्टर कह रहे हैं वो मेरे लिए ब्रह्म वाक्य है, मतलब भगवान ने जो कहा वही है हमारे डॉक्टर का कहना। तो अगर प्राइम मिनिस्टर या स्टेट की कोई भी बड़ी एजेंसी या उनका ग्रुप जो है वो डिसाइड करता है कि ये पार्टिकुलर ड्रग हम कीमोथेरेपी में देंगे, ये पार्टिकुलर ड्रग हम इम्यूनोथेरेपी में देंगे, ये पार्टिकुलर ड्रग हम टारगेटेड थेरेपी में देंगे, अनफॉर्चुनेटली टारगेटेड थेरेपी की मैक्सिमम दवाइयां, इम्यूनोथेरेपी की तो शायद कोई भी दवा इन योजनाओं में शामिल नहीं है। तो आप कौन होते हैं तय करने वाले कि ये कॉस्ट में इन्वॉल्व नहीं करेंगे? तो आप जीफेटिनिब खिला के कॉस्ट इन्वॉल्व कराएंगे जो 600 रुपए में जाती है बाजार में। तो गवर्नमेंट को ये सोचना पड़ेगा, और जो भी पेशेंट एडवोकेट्स हैं या जो डॉक्टर्स का ग्रुप है या जो फार्मा कंपनियां जो करती हैं काम, NGOs को ये सोचना पड़ेगा कि एक प्रेशर बनाए गवर्नमेंट पे कि साहब आपकी जो योजना है सारी दवाइयों को इंक्लूड कर दीजिए। कोई एक अस्पताल चोरी करता है तो आप पूरे देश भर के मरीजों को, करोड़ों मरीजों को उससे प्रभावित नहीं कर सकते। 14 लाख लोग डायग्नोज हो रहे हैं एक साल में इंडिया में। मैं देख रहा था डाटा इस सेंचुरी का 2000 से लेके और 2022 तक का 1.25 करोड़ से ज्यादा लोग मर गए, 1.5 करोड़ लोग। मैंने लिखा था नवा टाइम्स में एक आर्टिकल इसको, 1.5 करोड़ लोग मर जाएंगे और आप तय करेंगे कि कौन सी दवा हम देंगे किसी योजना में। मतलब हु आर यू टू डिसाइड दिस? कैसे कर सकते हैं आप? क्या नॉलेज है आपके पास? एक कमेटी 4 IAS की बन जाएगी। अब IAS कैसे बनता है भारत में? वो नॉर्मली ग्रेजुएशन करता है किसी भी स्ट्रीम से, और ग्रेजुएशन करने के बाद UPSC की परीक्षा देता है, सिविल सर्विसेज की, उसको क्वालिफाई करता है, उसकी प्रॉपर ट्रेनिंग होती है, फिर वो IAS ऑफिसर हो जाता है। और जब उसको पार्टिकुलर डिसीजन लेना होता है किसी एक मुद्दे पे, तो उनके एक्सपर्ट से राय लेता है, पूछता है कि हाँ मुझे ये करना है, कैसे करना है। अब से रोड बनाना उसको है, तो अगर वो इंजीनियर नहीं है तो उसको नहीं पता रोड कैसे बनेगा, तो इंजीनियर्स बताते हैं। तो आप दो मेडिकल के लोगों को रख लेंगे और आप सोचेंगे कि आपने डिसाइड कर लिया कि कीमोथेरेपी में कौन सी दवा आप देंगे और टारगेटेड थेरेपी की दवा को शामिल नहीं करेंगे, तो एक्चुअली यू आर चीटिंग योर कंट्री, आप चीट कर रहे हैं। और इसी पे बात करनी चाहिए कि अच्छे ड्रग्स हैं, इतने अच्छे डॉक्टर्स हैं इंडिया में। मतलब मुझे तो बहुत मतलब मैं बहुत प्राइड फील करता हूँ कि हमारे पास इतने अच्छे डॉक्टर्स हैं, इतने अच्छे हॉस्पिटल्स हैं, लेकिन रिजल्ट क्या है कि हम दवाइयों को ले नहीं पा रहे। ये डेटाज हैं अस्पतालों के। तो गवर्नमेंट को इंक्लूड करना पड़ेगा ऑल द मेडिसिन वी हैव इन इंडिया, जिससे कि कैंसर का ठीक इलाज होगा।
जी जी। Dr. Rauthan, in terms of, one of the big challenges, as you said, we hardly diagnose early stage lung cancer. In your views, what are the steps? First of all, do we have screening guidelines? And if not, what do you think can be done to improve early detection?
So, so early detection for lung cancer has been really very tough, and for various reasons. But if you look at historically also, it's not only in India, it's been very challenging all over the world. And there is so much awareness of breast cancer screening. And that's something that you talk of a mammogram, everyone knows about it. And they would have done a mammogram sometime or the other, and they would have heard about the screening programs of mammogram for breast cancer. But lung cancer is probably the most fatal disease. The way it is aggressive and the way the behavior is when it be detected in stage 4. I personally feel we would be very, very happy if we got more lung cancers in the early stage disease, because we know that's where the survival is much, much better. Now, the issue has been there have been screening guidelines which have come out from the West, and they are even in the West where the guidelines came out from, the screening rates are very poor. So the adaptation, the adoption of using these guidelines has never been very easy, and it's been very challenging. So what the guideline says from the West is, if any patient who's more than 50 years, between 50 to 75 years, who is a smoker, who's crossed more than 20 pack years of smoking, and they are the ones who require a low dose CT scan, and that's something which has to be done annually. And then you pick up a lump, a lesion, and if you pick up a lesion, then you move to the next steps. Now, this is something that has been quite challenging to do. Uh, Again, I would understand in India, we we have a huge population. We have heard all the issues which Raviji has mentioned. Cost has always been a major issue in India. So coming to screening has always been a backward step. It has been a difficult step, not backwards. It's been one of the most difficult steps. Our our all our thoughts go into treatment, and we all end up trying to say, let's treat patients. Let's try and do the best treatment possible for most of these patients. Let's try to reach out to the maximum. So prevention has always been very difficult. Yes, I would say if the guidelines get adapted and to that level, yeah, and if we follow the proper guidelines, we will definitely pick up more lung cancers in the earlier stage. But I think it will take time. This is something that will not happen very, very quickly. We really have to get to a lot of more information, a lot of more ability, and a lot of more technical advances to really get to level of doing lung cancer screening in India.
Right. And are there any guidelines even in the West for non-smokers? I think the only guidelines are on smokers, right? Or are there for non-smokers as well?
So this has been a majorly debated point, and these recently they have now started to include some new guidelines have been formulated for non-smokers. So this question always comes up because we always said smokers get squamous cell carcinoma, small cell carcinomas, adenos are more common in non-smokers, and we have seen adenos have now gone up much more than the squamouses. So there's now a recent adaptation of guidelines which are coming up even for non-smokers, but no, there's no absolute recommendation. All the recommendation guidelines are the smoking guidelines.
Right, because they're also, I mean, at least in India, and I don't know if globally, but it's also affecting younger people, right? So it's not it's not just 50 and above, for instance.
Yes. So the adenocarcinomas, the molecular driven, especially the EGFR ALKs, are usually the younger ones, and we see so many younger non-smokers like Ravi, and we have so many young females who are non-smokers, and they are
Correct.
developing adenocarcinomas. But the thing is, when we see such adenocarcinomas who are non-smokers, we are very kind of obsessed about finding a molecular driver. We say these have to have a cause there. They are not the
Right.
common ones, and we need to test them more and more. We keep saying, don't, if you get one test negative, just don't say, okay, this is negative and let's start basic chemo and leave it to what was the old way. We always say, get obsessed about testing more and more. You can do a tumor tissue NGS. Nowadays, we do blood NGSs. We just send the blood liquid biopsy for next gen sequencing. And those are also can pick up mutations which we have missed sometimes from the tissue. And that way, we try to find the molecular target. Incidentally, because you mentioned early stage, recently there have been new advances in early stage adjuvant therapy with molecular targeted drugs. So the EGFR space, they're saying if you get an early stage lung and you operate and then you get an EGFR mutation, by giving the treatment of tablets for 2 years or 3 years as adjuvant therapy is leading
Okay.
to a potential long-term cure. And this is the treatment is moving more and more into early stages, saying, can we prevent recurrences? Can we potentially cure more patients?
Right, right. Thank you. Thank you, Dr. Amit. Dr. Alex, we've talked of the possible areas of improvement in screening. Raviji's talked of the improvements in treatment or access to treatment. From a diagnosis standpoint and all of the testing standpoint, what would you see as, what would you want to see as areas of improvements, and what do you see as progress that's already happening?
Okay, so regard to the diagnosis part, I think NGS is the way, because you save a lot of tissue and you save a lot of time actually if you instead of doing everything sequentially, because we try to do the most common mutation as EGFR, and then if it's negative we go on to the next test. I mean, so NGS actually is the way to move forward. With regard to cost, definitely cost is a big factor because of the multiple tests we do here. So I'm happy to say that Government of India has an initiative. They actually started 3 to 4 years ago, wherein it's known as a Diamonds Initiative program. So it's actually mostly focused on the diagnosis of lung and breast cancer. So I'm talking about lung cancer right now. So they have actually started off choosing 4 nodal centers all over India. I mean, North Zone, West Zone, South Zone, East Zone, and over the last 3 years, actually this has increased to many centers. So that's like a wheel and spoke model. So what happens here is the patients, this actually helps the Government of India actually provides some financial incentive to run these tests free of cost. So there is that initiative going on. It's called Diamonds Initiative. So it's actually a collaboration between the Department of Health Research and ICMR. So many centers are now enrolled in this program. And actually, you can actually check our viewers, see if if their hospitals are actually enrolled in this program. So it's actually a very useful program.
So what does this initiative achieve for the patients?
So at least for the diagnostic part and the molecular part, it's all covered in this program. So they don't have to pay anything regards to this. So it's actually covered in this cost.
And where is this information available as to whether, XYZ clinic or lab is part of this?
I can probably share it with you later. I mean, I don't have it right away, but I can actually share the information.
Yeah, if you can do that, then we can make sure that we, put it up as well. So I think we don't have any kind of questions that have come in, but any more questions? But thank you so much, all of you, for your time. And I think if there's any final, word that each of you would like to share to the audience before we sign off, I will start with you, Dr. Rauthan.
I think a diagnosis of lung cancer should not be as scary as it was earlier. So that's something we keep telling our patients. We need to fight the disease. If we find a molecular target, go for a molecular targeted therapy. In the remaining patients, immunotherapy is making a big advance in lung cancer. We ourselves have patients who had stage 4 lung cancer who have done exceptionally well with immunotherapy, living a long life with a good quality of life. Unfortunately, not everyone responds. So that's where the whole science is moving forward, trying to find more and more biomarkers. But we always say, keep trying to fight the disease and use all the advances available. That's the way we look at it.
Right. Dr. Thomas?
Well, this is an evolving field. So discovery of new targets and development of novel targets are constantly evolving. So I'm sure we'll hear more and more information as years pass by, but it will get better and faster as well.
Thank you. Ravi ji?
देखिए मैं एग्री करता हूँ डॉक्टर अमित की बात से कि कैंसर इज ए डिजीज, तो वी हैव टू फाइट विद दिस। और सेकंड थिंग कि गवर्नमेंट ऑफ इंडिया को ये सोचना चाहिए और सोसाइटी को भी कंट्रीब्यूट करना चाहिए कि कैंसर पर रिसर्च हो। अगर रिसर्चेस नहीं होंगे तो हमारे पास नए एजेंट्स नहीं आएंगे, और नए एजेंट्स नहीं आएंगे तो मेरी तरह आप वेट कर रहे होंगे कि वन डे यू विल डाई विद लंग कैंसर।
Right. On that sobering note, I think thank you once again to our panelists and also to our audience for listening in. As we've been talking through, that there have been a lot of advances. This is a field which is continuing to evolve. There is progress that is rapidly happening. But as Ravi ji said, we need more research. We also need more financial innovation to make sure that whatever is, invented or kind of achieved is available for access to large numbers. So on that note, thank you once again, everyone. And if you would want to join, you can also join our session on myths and facts on 28th. Thank you so much.